Let's discuss diabetes mellitus now. It's one of those common conditions, and this is how common it is. The number has steadily gone up, and it's a concern today. There are two major types of diabetes mellitus, type 1 and type 2. Type 1 is also called as insulin-dependent diabetes mellitus, IDDM. It used to be called juvenile onset diabetes mellitus. Type 2, on the other hand, is non-insulin dependent diabetes mellitus, NIDDM. All right. Type 1 is where the pancreas is not able to produce insulin. In majority of the cases, it is an autoimmune disease where the tissue is destroyed, whether it is beta cell, whether it is an enzyme or insulin itself. So an antibody that attacks one or another part within the beta cell or the beta cell itself. So the destruction of beta cell that makes insulin. Without insulin, we will not be able to regulate glucose levels. And that's how you develop diabetes. And in here, a patient has to depend on insulin replacement. Type 2, on the other hand, is not related to the immune disease, but is related to many other reasons. One could be genetic, family history, environmental factors. Stress is one. Obesity is another one. So we will explore some of these details in the next set of slides. Adiposity, that is increased number of adipocytes, basically obesity. And then insulin resistance, insulin insensitivity. There is a strong relationship between obesity and insulin resistance. The way fat cells react to insulin is quite interesting. So when do you call it hyperglycemia? What is the normal level? And when do you call it hyperglycemia? Normal levels are anywhere from 70 to 110 milligram per deciliter, normal range. This is the fasting glucose level. Then there is that window between normal and hyperglycemic. That is what you call as pre-diabetic. That's where you bring in 110 to 125 range. And over 126 milligram per deciliter is where you say it is hyperglycemic diabetic. Okay. Here is a beautiful comparison of type 1 and type 2. Okay. Type 1 is not related to obesity, whereas type 2 is. About 80% or more of the patients with diabetes type 2 are obese. And type 1 is more common in Northern European descent, whereas type 2 is more common in African descent and in among Native Americans. Both type 1 and type 2 have a genetic component related to the disease. Type 1 is where you depend on insulin. Type 2 depends on what state of the disease they're in. We will look at different states in type 2. There may be too much insulin there may be very little insulin. So the situation changes. And depending upon the condition, you may or may not use insulin. In type 1, insulin secretion is an issue. We do not have normal levels of insulin. Whereas in type 2, it could be hyperinsulinemia, too much insulin, and sometimes the levels would be less than normal. Insulin resistance is not common in a type 1, but is very common in type 2. Autoantibodies are the ones that attack the tissue and destroy beta cells, and that is where type 1 is an autoimmune disease and type 2 is not. Ketosis, we'll talk about this in greater detail. Ketosis is increased amount of ketone bodies in the blood. It's very common in type 1, whereas in type 2, it's not so common. Okay, let's focus on type 1 first and then type 2. You already know that it's an autoimmune disease. Immunologically mediated destruction of beta cells or insulin or an enzyme called glutamic acid decarboxylase. The sad part here is about 70% of the tissue would be destroyed by the time you see the symptoms of diabetes. It would be too late to do anything. There may be a small percentage of non-immune type 1 diabetes. This is typically due to pancreatitis. That is repeated pancreatitis or chronic pancreatitis and destruction of beta cells with the destruction of other cells there too. Or it may be due to the increased production of glucagon. Glucagon is another hormone made by the pancreas. It works as an antagonist of insulin. Okay, so maybe it's a good time to discuss what insulin does and what glucagon does. It's just a review of physiology for you. Insulin stimulates the uptake of glucose from the blood into the cells. And once glucose is in the cells, it stimulates the formation of glycogen. Glucose becomes glycogen. Excess glucose is converted or sent to adipose tissue where it could be converted into fat and stored there. And it prevents glycogenolysis. It prevents the breakdown of lipids. So it basically guards glucose in the storage form. So it's called an anabolic hormone. Anabolic hormone because it builds the larger molecules such as glycogen and lipids. Glucagon, on the other hand, is the one that releases glucose into blood. So glucagon is secreted only when blood glucose levels are low. So we really need glucagon's help in raising blood glucose levels back to normal. So how does glucagon accomplish this? One, by breaking down glycogen to glucose. Two, by using fatty acids, using amino acids and other non-carbohydrate sources to convert those into glucose. That's what we call as gluconeogenesis. This typically happens in the liver. So glucagon's goal is to break down lipids, break down glycogen, and raise blood glucose levels. All right, so with this, we'll move on to look at more details about type 1 diabetes. So we know that there is a genetic component, first degree relative, parent, sibling of that sort, and strong association with the major histocompatibility complex. Again, this is to do with the immune component. Okay, environmental factors that may be involved, viral infection, H. pylori, are connected to type 1 diabetes as well. That affects the pancreas, and therefore pancreatitis, and then diabetes. So all of those are shown here, and now beta cells are destroyed, and that leads to type 1 diabetes. Okay, now we need to understand some chemistry. Yes, there is quite a bit of biochemistry here, unfortunately or fortunately. Let's see how we make it simpler. Okay. In type 1, we know that insulin is not produced in sufficient amounts. Without insulin, cells are not able to get their quota of glucose, which means they cannot generate enough ATP for their day-to-day maintenance, correct? So they are starving. They're starving. Now, neurons depend solely on blood glucose. And now, when you do not have enough glucose into the cells, what happens is they're starving too. And the only two things they can use is glucose and ketone bodies. They prefer glucose, but they can also use ketone bodies. These are the two they depend on. All right. So how do we generate more glucose? This is where we look for sources of glucose. One source is glycogen. This is the storage form of glucose, which is typically present both in the muscle cells and in the liver cells. So that would be now broken down. Glycogen is converted to glucose. And you also want to look at the sources of lipids. Breakdown of lipids, lipolysis, then the proteolysis, that is, proteins are also targeted. All right. So you are basically looking for other sources. Why? Because you're starving, you're not getting enough glucose, and we just want to scrape anything and everything that we can find around and use it for energy purpose. So lipolysis, this happens in the adipose tissue. Glycogenolysis could happen in the liver, in the muscle tissue. Proteolysis, again, muscle and other sources of protein releasing amino acids. So all of a sudden, you're looking at increased levels of fatty acids, increased levels of amino acids. These fatty acids and these amino acids can be converted into glucose. Okay? Can be converted into glucose. Now, when fatty acids are around, partially digested fatty acids, about 3 to 4 carbon structures, are referred to as ketone bodies. So, digestion of lipids resulting in 3 to 4 carbon structures, ketone bodies, would certainly be in greater amounts. Okay, and that's what you refer to as ketogenesis. Ketogenesis, increased levels of ketone bodies. Okay, that's when you use the term ketosis. Ketosis is higher levels of ketone bodies in the blood than normal. Okay, and obviously hyperglycemia. How do we get hyperglycemia? Because you're breaking down glycogen. You're also using another process, that is gluconeogenesis. Gluconeogenesis. And how do you do that? By using the fatty acids from lipolysis, amino acids from proteolysis. All of that results in output of more glucose into blood from the liver, pretty much. So that is how you have hyperglycemia and ketosis. This is what we really wanted, right? Because the cells are starving and we need to provide them with some substances that they can use. Can they use it? Basically, no. Why not? Because there is no insulin to make cells use these substances. Okay, so now 2 sources of glucose released into blood. Remember this. One is from the liver. How? Through all these reactions we talked about. That is glycogenolysis and gluconeogenesis. You are producing glucose and releasing it into blood. So that is from the liver. So one source is from the liver. And the second source is from the diet. If you're eating food, that is also releasing glucose into blood. So you are loading blood with glucose, and that is going to make us have more than normal levels of glucose. That's what you call as hyperglycemia. All right, so you have a biochemical triad at this point: ketonemia, okay, hyperglycemia, and acidemia. Ketonemia, blood levels of glucose is very high. That's what you call as ketonemia. Hyperglycemia, we already know what that is, greater than normal levels of glucose. And then acidemia. How did we get the acid here? Now, ketone bodies in large amounts can make the blood become acidic, and that is how acidity is another issue at this point. And this is because of ketone bodies. And this type of acidosis is called ketoacidosis. Ketoacidosis. So that is all pretty dangerous and can be fatal if it's not controlled. So these are 3 bad sets of events. You're talking about high levels of ketone bodies, high levels of glucose, and acidic condition. There you go. Now you're actually looking at a condition called diabetic ketoacidosis. We already know the definition. Ketoacidosis is increased levels of ketone bodies changing the blood pH to be acidic. All right. So what does it do? These are some signs, symptoms, clinical situations that we need to understand. Volume depletion. Okay. Now, why is there volume depletion? One, a patient with diabetic ketoacidosis could be vomiting, loss of fluid. And then the other thing is, because this patient has hyperglycemia, some of the glucose spills into urine. When you have glucose in urine, water follows glucose into urine. That means your urine output is now greater than normal. That means you're losing water in the form of urine, you're losing water in the form of vomit. That's how you have volume depletion. And tachycardia, this is all because of the acidic condition. All right, hyperosmolarity. What is this? Hyperosmolarity is so much glucose in blood is making the osmotic concentration be greater than normal. Normal osmotic concentration is 300 milliosmol. Now it would be much greater. 1, you're losing water. 2, you have a lot of glucose that's not going anywhere. Not into the cells, I mean. All right, so nausea, vomiting, hyperosmolarity, volume depletion, tachycardia, abdominal pain. Abdominal pain is basically because of all of these events. And what's happening is acidic environment, irritation in the GI wall. That's how there is abdominal pain. And because of the loss of fluid and lack of energy and nutrients, a person is lethargic. Okay, no energy there. Acidosis, hyperosmolarity, and dehydration. This combination that you're looking at could affect the consciousness of a person. Okay, a person is very distorted and confused, and now he may lose consciousness to the point of coma. So this is a really bad situation. Clinical manifestations, polyuria, that is more than normal urine output, and dehydration, we talked about this. Small respiration is like faster breathing in response to acidosis. You have metabolic acidosis, so you need to, the body is trying to get rid of the acidity by producing more, removing more CO2. And fruity odor is because of the ketone bodies. Okay, it has the distinct smell. Then the lab values, you have definitely greater than normal levels of glucose, over 250 milligram per deciliter, and pH is less than 7.35. Ketones in urine. When you have too much ketone in the blood, some of it spills into urine. All right, and the total body potassium depletion. If you have insulin, it promotes potassium entry into the cells. Now there is no insulin, so potassium is leaving and is being lost. So that would be another major complication. It has to be treated as quickly as possible, and the patient must be treated with insulin right away. And because of dehydration, you have to work on the fluids and the electrolytes.